I'll now move on to the section around group clinics and lifestyle medicine, and this is the part where I introduce Georgina to you, who will just give you a brief overview.
Hi, everybody. It's lovely to see you all. So, just before I hand over to our first speaker, I'm just going to very quickly say something about group clinics and lifestyle medicine and why the fit is so perfect. You may know, if you're part of the British Society of Lifestyle Medicine, that one of the skills that they suggest you adopt or learn is to actually run group clinics. And we decided to do the webinar as we are today because we know that lots of people are really interested in lifestyle medicine, and finding the time in your clinical practice to embed lifestyle medicine can be very, very challenging because it does take some time. And so we wanted to hear from two clinicians who have actually helped use group clinics to help them to mainstream lifestyle medicine in their practice. So there are three principles of lifestyle medicine practice. The first one is to recognize and work with the social determinants of health. So that's recognizing that people's environment, their housing, their income has an impact on their health, and being able to work with them to help them to overcome those wider issues that within their life. The second one is developing specific skills that as a clinician or another practitioner to support you to deliver lifestyle medicine. And I've got a little slide summarizing those, and one of them is group clinics. And then the third part is to recognize and work with people around the lifestyle pillars and make sure that they are embedded into your work. And when we do lifestyle medicine group clinics or group clinics that are focused on supporting people to improve their lifestyle, that is often the topics that are on the boards that Alicia has just introduced you to. And I know certainly in Sue's case, that's what she focused hers around. And I'm sure she'll tell you some more about that when she shares her work. So next slide. So here are the lifestyle medicine clinical skills that you need to develop. So as you see, group consultations, also group no, another name for group clinics is mentioned there, as is health coaching, social prescribing, delivering person-centered care, motivational interviewing skills, and behavioral cognitive therapy are all seen as part of the kind of stable of lifestyle medicine. And the interesting thing is that actually coaching skills, motivational interviewing really support the delivery of the group clinic model. And the group clinic model has been analysed through systematic reviews of controlled trials, and both patients and professionals feel that the group model of care is more personalised than one-to-one clinical appointments, which is really interesting. And it makes you realise that this is why they are such a close fit with lifestyle medicine, because they deliver a huge number of those skills and provide a forum for those skills to be practiced. So that's just a very, very quick kind of rationale. And now I'm going to waste no more time and hand you immediately over to Jackie. Jackie, are you there?
I am. Hello. Are you going to move the slides on for me, Georgina? Oh, you're on mute.
Oh, yeah. Alicia will do that for you.
Fine, I'll just make it clear. Hi, everyone. Thanks for listening today. Thanks for coming. So I think to start with, just you can't put your hands up because there's too many of you, but just metaphorically put your hands up. Who feels that the endless telephone calls and online consultations in general practice feel like we've lost the art of medicine a little bit? Yeah, I mean, Sue, obviously, I'm sure she's, but I'm sure lots of people will agree. I know my colleagues agree. And I think lifestyle medicine and then group clinics are offering us a way back, and that's certainly how I see it. But in day-to-day primary care, in my practice, lifestyle medicine probably still isn't mainstream, and we're getting there. And what I want to share today is how we've tried to make it more mainstream through projects, mainly including the group clinics with Georgina's support at Whitstable, and sort of what we've learned along the way and the challenges. So just moving on to the next slide. Whitstable PCN is a single practice PCN. So we're one practice, one PCN, which does make life a little bit easier. We cover Whitstable and the surrounding areas with about 45,000 patients. I've been a partner there for over 19 years now, and a GP trainer for 15 of those years. I've also been education lead for the PCN for the last 5 years. We've got 24 GP partners, mixture of full and part-time. It's a lovely place to work. It's by the seaside, famous for oysters, in case any of you haven't heard of Whitstable, which apparently are nutrition powerhouses, but I've still not eaten one ever. We've got a big urgent treatment centre. We've got lots of other clinical services, same-day emergency care. So it's a very big practice. So moving on. The next slide, please. Thank you. Yeah, so I think my journey to embrace lifestyle medicine probably started a long time ago, but if we go back to around 2018, I had some health issues myself, a background of ulcerative colitis, which was sort of controlled, but not brilliant. And then just developed really quite severe fatigue, which nothing medical was really helping. All the tests were normal. And really the only thing that helped me to get better was essentially what I didn't know at the time, but was lifestyle medicine, nutrition, exercise, sleep, all the things that a lot of us now know about. And I think like any GP or clinician that sort of had a bit of a health problem themselves, I then obviously wanted to know more and saw how much it could help my patients. So I did a Dr. Chatterjee course initially before COVID, and then joined the British Society of Lifestyle Medicine and did my core accreditation last year, which was brilliant. But within the PCN, in the practice, I really felt like a lone voice. I felt like a bit of an oddity, a bit of the odd one out. People a bit, cynical about it, possibly. And I think the final straw came when people were talking about embedding or putting junk food vending machines in our urgent treatment centre, because patients apparently needed that because they were waiting for an hour. And I thought, no, something needs to change. And I think what I did and what I'd suggest to everyone is try and just seize an opportunity. And we have these learning afternoons where we have the out of hours service will cover. And partly because of my education lead, I was able to organise a lifestyle medicine learning afternoon. One of my colleagues did. And actually, interestingly, suddenly I didn't feel like the odd one out anymore, because when you did it to the whole practice, clinicians and non-clinicians, there was actually a huge enthusiasm and interest, and people could really see the need for lifestyle medicine. And off the back of that, we set up a special interest group that meets a few times a year. So again, and I'd sort of say, get your early adopters, get your enthusiasts, and bring everyone else along with you later. And that's, I think, how we've sort of done it, really. And actually, it was better for me to have those early enthusiasts, because you didn't feel like the odd one out, and it gave you that confidence to move forward. Then we were offered the group consultation training with Georgina and her team. And we grabbed the hat because our training hub provided some funding for that. And that then enabled us to sort of move on with group clinics. So just moving on, I will talk about the challenges, because I think it would be unfair to say there's not been challenges, and there continues to be, because like any big change, there's going to be some challenges. I think just I broadly put them into these categories, but clinician mindset is definitely one. You will get colleagues that are cynical about lifestyle medicine and the benefits. Some people have a preference for randomized control trials, for giving medications, but even some of my most cynical colleagues are much more supportive now of the whole thing, the lifestyle medicine and the group clinics, and I'll explain perhaps how we've won them around as we go. There are practical barriers. There's no direct payment really to do lifestyle medicine in general practice or primary care. I'm a partner. I've got one head to the business and the money, and I'll describe how we've used some sort of ways of the group clinics particularly to sort of find a way to do lifestyle medicine in a way that is financially viable. It's taken a lot of time and effort, both on my part and the team. You might need space if you want to do face-to-face clinics, but the online does provide, an alternative. I think there's definitely a fear of group consulting, of being exposed as not knowing enough amongst some clinicians, and some clinician discomfort perhaps about their own lifestyle as well, about, particularly with lifestyle medicine, maybe their own lifestyle wasn't as good as it could be. And then you need to really engage the team, because I think reception staff, it's another change for them. They're super busy, and obviously people were unsure, patients were unsure, and there is an element of selling it and marketing that needs to happen. So moving on to the next slide, which is the enablers, I think you need to be a bit of an unapologetic champion for it. And that's why getting my early adopters and enthusiasts helped give me the confidence to do that. you need to be, a committed champion for it, really clear systems and messaging. There's some really simple practical supports we've done, like set up preset text messages on our system so that it's easy for reception to send out appointments. That links to our website, which has got lots of information about group clinics, what they are. Georgina's helped with some of that. Financially, we've used, not always, but some of our group clinics run in extended access appointments. Some of the nurses wanted to do some evening work. It suits their family life. Actually, patients are more likely to be able to attend. And actually, that's a way we're being paid separately to do those. So it kind of works from a financial perspective as well. And having really good admin support. I think everyone always says that, but that's really important. I think the training was absolutely key, because much as some of us, particularly doctors, sometimes are quite happy just to jump in and do something, I think a lot of the staff weren't, and without the training they would never have had the confidence to be able to start. And being really supportive, like a multi-professional approach. So although I don't actually now do the group clinics, I'm not the clinician, I spent a lot of time going to all the early group clinics myself, sometimes in my own time, just to get it going, to kind of give them that confidence and then withdraw as they gain confidence. And patient engagement, lots of stories, use stories, patient stories really help, and quotes. And do marketing. You actually have to market it, social media, website, patient user group, we engage with them as well. So moving on, at some point, you just have to get started. That's my other tip, is that you can't spend forever planning your training. You have to just do something and get started. We started with menopause because at the time it was a really high demand area. So my other big tip is solve a problem for your practice. If you've got colleagues that are not sure, if you solve a problem for them, so whether that's a long wait for appointments in a certain area, or in this case, a lot of the GPs were moaning a bit about doing menopause care. A lot of them didn't really enjoy it. There was a sudden surge in demand. So I sort of slightly grabbed that. We had nurses that were really interested and wanted to train up in having a special interest. So it was great from my education lead point of view to get them going on that. So we started with menopause. We started online. One of the challenges we had was people not turning up online sometimes. So we've actually swapped it following feedback to face now, which I think is more popular, interestingly, with patients. And we're using the extended access slots for the sort of financial viability of it. GP support was definitely key early on to give them the confidence, but they don't actually need me. They know far more than I do about the menopause, but I think it gave them the confidence. And we keep reviewing and adapting. We don't always follow the exact model. So yeah, we keep adapting. And then moving on to the next slide, we've then expanded it. So particularly diabetes, if you think diabetes, it so clearly lends itself to group care, but also lifestyle medicine. We started with a pilot a couple of years ago with newly diagnosed type 2 diabetics, and we then adapted that, and we've now got a 2-session model. So one of our specialist diabetes nurses runs it with the health coach in the practice as the facilitator. There's the two of them face to face, and everyone who's newly diagnosed comes to that. Patients have actually been really appreciative of that, actually far less problems getting people to come to that sometimes than the menopause group. And it's really embedded in the pathway now. People bring along carers and things. I think the other thing that's happened is, and again, by getting those early adopters and just starting something, you create a bit of a buzz, people start talking about it, you advertise it through our practice newsletter and things, and then I get the pharmacy team coming to me saying, well, actually, we want to do this. We're a bit fed up with, they were doing a lot of the statin work, so they were talking over and over again about the same things, you know, repeating themselves, and realising they weren't really doing any lifestyle advice because they didn't have time. They spent all their time talking about statins. So they asked if I could help them set up cholesterol groups, which we've done over the last 6 months or so. They're going really well. They're face-to-face in the evening. We do run slightly bigger groups for that, partly just through necessity. So again, we slightly veered from the kind of model, but I would say, like Alicia said, it's somewhere between group education and group clinics. So we have adapted the model to suit us. And I think having the confidence to do that's really helped, because I don't know otherwise that we'd have been able to do it. And we just keep tweaking it and keep changing it. Physiotherapy team have set up persistent pain groups and pelvic health groups for menopausal women as well. And then the latest project is that we have a dermatology service, and one of our expert patients who's transformed her eczema with nutrition, one of my patients, she's actually now going to co-facilitate that with our specialist nurse. So that's starting in a couple of weeks. So we'll see how that goes. So it's definitely creating that buzz kind of helped. And just finally, going on to the last slide. So just in summary, really, my reflections are what makes lifestyle medicine work in primary care. I think, first of all, you have to ignite interest. Now that's going to be different, I think, for different PCNs and different practices. You've got to find a conversation starter within your group of people, whether that's about group clinics or lifestyle medicine. I think try and solve a problem for people, whether it's something people don't like doing, like the GPs often, or whether it's a long wait. Like we had really long waits for people newly diagnosed with type 2 diabetes were waiting 2 or 3 months to see a nurse. The nurses were really unhappy with that. So again, that was a real opportunity to get in there and sell the group clinic idea to them. I think recognise that the training in itself can energise the team. People like doing it, particularly face to face, we've found, because it's a bit of an antidote to some of what we're doing in primary care now. And it helps staff retention if you develop your team and give them training in new things. The group clinics has sort of been the real world mechanism for us to do that. Target problem areas, I've said. And I think embrace and act on feedback. I think initially I was quite defensive because it was my project, and it's easy to sort of worry if things aren't going well, but actually if you take the mindset that actually take the feedback from colleagues, from patients, and actually use it to change and tweak, then that's actually a more positive way. And I think create a culture shift, because it can be contagious. If you can create a buzz around something, I think people want to be involved, they want to ask about it, and they'll talk about it in your community, which helps with recruitment for patients. But yeah, and I think it sets you up really well to take on things for the 10-year plan. I know at the moment there's not brilliant funding, but actually the 10-year plan does talk about prevention. They have, NHS England are very aware, as we know, of group clinics. So I think the more you can get some of this in a financially viable way into your practice, you'll be set up really well potentially for future projects that NHS England or your ICB offer. I feel like we're in a good place now to be ready to run with anything. But yeah, so thank you very much.
Jackie, that's amazing. And do you mind also just saying a little bit? I know when we did some evaluation with your team, you talked about how it had impacted on you as a sort of clinical leader, and I think that's would also just be worth a little mention. By the way, I think you've given everybody a really, really great little checklist of how to overcome some of the barriers there. Particularly, I just love your, all the GPs were moaning about menopause. So we decided to do menopause because actually, of course, they're going to say, yeah, that's brilliant, great. So I think that's a really important little tip. But just give us a little flavour about the leadership, how it affected you as a leader.
I think if you take my leadership role as being partly education lead, and also wanting to lead on lifestyle medicine, having got my core accreditation, I wanted to do stuff with the practice. And I don't think anyone was inherently against me doing stuff with the practice, but really until we started doing the group clinics, it was a little bit of a sideline. It was, yes, you can have an evening meeting, people can do it in their own time. And lots of people still came to the meetings in their own time, which was lovely. And we had lots of projects. We're an RCGP active practice, we do park run, all those sort of things. But really the group clinics, I think, then gives you a concrete thing that you can lead on. You've got proper training. That really helps with staff, as I said, staff retention. And I think for me, it gave me a framework there where we can offer lifestyle medicine in a way that actually, as a partner, because I'm a partner as well, so it needed to be financially viable for me to buy it, even though I probably would just do it and spend the money. I know my colleagues are not going to go for that because you have to have an eye to the business and paying staff. So I think the group clinics has been a way to do that. And I think because it's now more of a recognised thing, that's helped as well, because it's not just us. Initially, we were probably one of the people who hadn't heard of it. Now it's talked about in loads of forums. People are like, oh, well, we're already doing that. And then they feel proud. And then that helps, with so we just keep doing it. I feel like it's embedded, but we just need to keep working on it, tweaking, changing.
It's as all healthcare is, isn't it? It's a continuous process of improvement. So that's really helpful. And I think that's the thing. I'm sure we've got lots of people on the call today who are kind of lifestyle medicine, enthusiasts, and to be able to lead the change towards lifestyle medicine through the group clinics is a real, as you say, it's a practical thing you can do, isn't it? So if you've got any questions for Jackie, do pop them into the chat. I'm going to move straight on to getting Sue to share her story, which is what I love about doing these webinars is I get to choose the speakers and get people who are just doing completely different things, but with similar results. So it's over to you, Sue, to share your story.
So hi, thanks Jackie for that absolutely brilliant talk about using group clinics in the NHS. In fact, you might have got, sold it to me so much I might come back to NHS general practice. Anyway, I'm Dr. Sue Law, and I run Improve My Health, which is a small lifestyle medicine social enterprise which aims to make the world a better place by changing the way healthcare is delivered, which I assure you is every bit as challenging and as exciting as it sounds. And group clinics are key to how I think I can do this. So next slide, please. So a bit about me and how I discovered lifestyle medicine. So for me, like all the best things in my life, it happened by accident. So as I said, by training, I'm a GP. I worked as an NHS GP for nearly 20 years. I spent most of my career working in very deprived inner city Plymouth, which isn't everyone's cup of tea, but I loved it. And for the last 10 years or so, I've also worked one session a week in occupational health with bus drivers. In the past, I would describe myself as a fags and booze doc, meaning like many of my colleagues back in the day, I used to smoke and drink far too much. I don't smoke anymore and I drink much less, but don't quite have the abs of our friend on the slide here. So how did I get from a fags and booze doc to running a lifestyle medicine business? It was a bit of change of course. So at the end of 2020, I was returning to work after 2 lots of maternity leave in quick succession. I was feeling a bit out of date. That was returning to work as a NHS GP. I was feeling a bit out of date and I felt like I needed to refresh my knowledge. I'd moved house, I had a longer commute, so I thought I'd use the commute to do some CPD. And I started listening to podcasts such as Doctor's Kitchen and Feel Better, Live More, and also as a patient living with a chronic health condition, this notion of doing things to improve my own health just ignited something in me. And I've heard lifestyle medicine described as us medicine, which I guess is what I really felt. So this related to me and my patients. I then discovered the British Society of Lifestyle Medicine in 2022, and I did the diploma then, which is now called core accreditation, and I'm now an assessor for the core accreditation. So after my diploma, I was all bright-eyed and bushy-tailed and wanting to go out and use my newfound knowledge to save the world. But unfortunately, I was burning out and falling out of love with NHS general practice. And I did try and integrate lifestyle medicine into my GP consultations. I did the best I could, and I used to send accurate texts with, podcast, books, website recommendations, but I suspect these were never opened. So I thought, well, what now? What, do what you know, and I know about bus drivers. So next slide. So what could I do with bus drivers? Well, professional drivers have a higher than average rates of chronic lifestyle related illness. And as you can see from this infographic, which was kindly shared with me by Professor Stacey Clemes at Loughborough University, that they're nearly all overweight or living with obesity. They have high rates of high blood pressure, high rates of inactivity, and less than perfect lipid profiles. Also, the link between sedentary lifestyle and heart disease was made by comparing rates of heart disease in London bus drivers and bus conductors in the 1950s. So we've got a problem. What can we do about it? Well, as doctors, we see drivers for their routine DVLA licence renewal medicals. And at Go Southwest, we added a 15-minute lifestyle medicine appointment to every licence renewal medical. Next slide. So and we were getting some really good results, and I was quite surprised that in 15 minutes we could actually get such good results. So the drivers liked the appointments. They rated them as nearly 10 out of 10 for usefulness. After the appointment, 97% were considering or planning to make changes. And when we followed them up to 9 months later, 76% did go on to make changes, and then 84% were still doing those changes. And examples were things like cutting out unhealthy garage food, changing to drinking water rather than energy drinks or fizzy drinks, swapping chocolate for dark chocolate. And these were people who weren't coming to me asking to, how they could be healthier. These were bus drivers who were just rocking up for their routine medicals. But what about these group clinics? So next slide. So I had heard about group clinics doing the BSLM diploma, and I'd thought, ick, perhaps not for me. So sorry about that, Georgina. I was like, why on earth would anybody want to discuss their medical problems in front of other people? But despite my good results with the one-to-one appointments, there were some issues, and those issues were namely time, repeating myself, and sort of running out of energy. So time, it's a miracle, but largely in my lifestyle medicine and driver renewal clinics, I do run to time, but which I don't in general practice by any stretch of the imagination. But 15 minutes isn't that long, and I could do more if I had more time. People, so repeating myself like my Polly Parrot here, like people generally have the sort of same issues, and I would find myself saying the same thing over and over, and forgetting who I'd said, what to, and kind of that's not ideal. And also sort of running out of enthusiasm. So in order to make any sort of impact delivering lifestyle medicine, you've got to be enthusiastic. You can't just tell people what to do, but you've got to find a way of helping them to work out, what changes they want to make and how they might fit into their lifestyle, into their lifestyle, and kind of doing that takes energy and enthusiasm. And my clinics were 4 hours. It was straight the way through. I did back-to-back patients, and I have to say, by the end of that clinic, I would sometimes have run out of energy. I hope I'm not the only one who gets a bit like that. Next slide, please. So we co-designed. So I thought, well, what about these group clinics that I've heard about in my lifestyle medicine training? Well, we co-designed these fit for work groups with the managers for people with the highest rates of sickness absence. Georgina, so I'd never done group clinics before, and as far as we know, group clinics aren't being run in the community in an occupational health setting. So I had my training through ELC, and Georgina kindly came down and was my facilitator for the pilots that we ran in January. Our model was very much based on the group clinic model. So we had the clinician, the facilitator, and we had up to 10 participants. And these were the people with the highest rates of sickness absence. And we evaluated them using two simple questions, which are, how good are you at taking care of your health, which is used by the National Academy of Primary Care to assess change, and it's a simple measure with just four points, so from not very good to excellent. And the NAPC have shown that this correlates with up to £127 of NHS cost saving per patient per year. And as my topic board, I used the pillars of lifestyle medicine, like Georgina mentioned. So next slide, please. So in our group, so we have the diverse range of people living with a diverse range of medical issues. We had drivers living with common medical issues such as back pain, arthritis, depression, IBS, fibromyalgia, obesity, menopausal symptoms, previous substance dependence. The most common issues were obesity, depression, and musculoskeletal problems. So these are people living with multiple medical and social issues, very similar to the patients I saw in NHS primary care. And despite their differences, they spontaneously found much common ground and shared experiences. The themes we discussed were things like driver stress, and this was a big one here, healthy eating, chronic pain, weight management, and they were really well received. And nearly all participants commented that they enjoyed talking in a group, and that was the very thing that had put me off initially. So it shows how much I know, and every day's a school day. And things that they wanted were longer sessions. Apparently 2 hours of me droning on, because our sessions were a bit longer, they were 2 hours. It isn't enough for them. And they also wanted us to consider focus sessions on different pillars of lifestyle medicine, and to set up a fat club, their words, not mine, to support drivers through weight loss. So next slide, please. And importantly, we achieved an average 1 point increase in activation, which could correlate with over £2,000 of healthcare costs, so NHS costs per person, for the people in the group per year. Next slide, please. So what were my experience of group clinics? Well, like Jackie said, it wasn't all smooth running. It took us several attempts to get going. The first 2 tries, we invited anyone along who wanted to come and talk about their health. Like Jackie said, as a GP, sales and marketing are definitely not my forte. In the NHS, I had plenty of customers wanting to come and see me without having to advertise my services. I was also not very good at explaining what a group clinic was and why it would be beneficial, and also in targeting those who were most likely to benefit. And for me, it was especially hard work, as I don't work at Go Southwest all the time. I'm only there a few times a month. So I was relying on other people to be enthusiastic about something they didn't really understand and to spread the word. Also, bus drivers are notoriously bad at reading their emails, so getting at them was quite hard. But after 2 unsuccessful attempts, we took a different approach and we worked with the managers to target those most likely to benefit. So like solving a problem, like Jackie said, and that was those with the highest rates of sickness absence. And we facilitated those people by getting them off their shifts and things to come along, and bingo, off we were. So from my point of view, it's the most fun I've had consulting in a long time. And working in a group improved the issues I'd had around time, repeating myself, and my energy that I'd had in the one-to-one consultations. And I've gone from ick to in love. And, you know, in my 25 years into my career with likely another 20 years more to do, it's good to have something that sort of energized me and it's new and different. I find it really difficult to explain the magic of the group. Here is a picture of me delivering a group clinic at Global Plymouth, which is an event hosted by Plymouth University. And in that group, I had an age range from 90 to 90, so 19 to 90, and I'm not exaggerating. And there is something incredibly humbling and powerful about a young patient with multiple problems, including fibromyalgia, complex regional pain syndrome, ADHD, etc., sharing their sleep tips with a medical student who's trying to avoid burnout, and watching everyone in the group, including me, benefit from the experience. Also, in my experience as a clinician, in a group clinic, you can sit back and let the group do the work, and you occasionally have to steer them in the right direction if they wander too far away from evidence-based suggestions. And that's interesting, but the studies would suggest X, Y, and Z might work every now and again, can work well. One thing that I would like to point out is that in this picture, in this group clinic, for whatever reason, for a number of reasons, I didn't have a facilitator. Big mistake. All right, timings went completely to pot. People had to leave before the end. Not everyone got their one-to-one. But despite all these things going wrong, I still got lots of positive feedback forms on how much people had enjoyed the group. So what I would say is, even if things don't go according to plan, patients and the participants will still benefit. So don't worry too much about getting it perfect straight away. So I'm such a convert that my little business, Improve My Health, is specialising in delivering group clinics to communities and companies. And at Go Southwest, I'm now regularly delivering Fit for Work group clinics. I'm doing one next week, so if anyone's local and wants to come along, you're very welcome to come and see what I do. And also, Go Southwest is part of the a bigger Go Ahead national group, and I'm due to meet with the leaders at Go Ahead to look at ways of emulating the good practice elsewhere. So wish me luck. I'm also developing a group clinic package with a series, which will be a series of group clinics, each one based on the pillars of lifestyle medicine. And as I said at the start, my professional heart lies in deprived inner city Plymouth, and I'm working hard with community groups and the voluntary sector to look at taking group clinics into the community. And I feel that the lifestyle medicine delivered through group clinics fits really well with the NHS 10-year plan, and also with neighbourhood health services. And I'd really love to be part of delivering group clinics in deprived areas. So again, if there's anyone out there who can make that help, do get in touch. So last slide, please, or next slide. So my top tips are much the same. So just start, all right? Be enthusiastic, do your best. Don't worry about being perfect, all right? Get your team on board, as they're key to getting the patients to turn up. And don't forget to explain simply and clearly what a group clinic is and why they are beneficial. And think like a marketing or salesperson rather than a healthcare professional. So think like a patient. Think about what's important to the patient. So like if you're looking to run a group clinic for people with diabetes, you might be interested in their HbA1c and target for QOF, but they might be more interested in not getting their toes chopped off. So ask your team, ask your nurses, because they will know what patients are most worried about. So for me, with bus drivers, it's failing their medical because they've got high blood pressure. One thing I find putting on my posters, writing, have you ever wanted to spend more time with a GP in have you ever wanted to spend more time with a GP? Putting that on the leaflet, that works quite well. So finally, so my name is Dr. Sue Law. If you've got any questions, queries, want to come in and join the fun, then do get in touch, and my email address is here. Thanks for having me.
That's great, Sue. So we have had a few questions in the chat, but they haven't been specifically aimed at either of you two. So if anyone has got any questions, we're rapidly running sort of towards the end of our time. So, but if you've got any particular questions for Sue or Jackie about their particular models and what they're doing, please do pop them into the chat now. As Sophie says in the chat, really inspiring. And it just goes to show you that you can work in, different ways with group clinics to embed lifestyle medicine wherever you're working in the system. And that's really, really good. I also think it's really important, and you certainly didn't need to apologize, Sue, for being a doubter in the early days. As you can imagine, as we've been working on this for 10 years now, you're not the first person that I've come across who has started out being very skeptical and ended up being a complete convert. In fact, often the most skeptical people at the start end up being the biggest converts. So, I think it's really good for everybody on the call to hear that honest kind of insight from you, that actually, people are skeptical. I think what Michelle from NHS England popped in the chat, this sounds like such a really different way of working, and that's the truth, isn't it? It is. It's a disruptive innovation. It takes clinical care and it completely changes it. It disrupts the power base. It disrupts the way that clinicians have to work with patients, giving them much more agency, making them much more equal partners in their care. They can't escape their responsibility for taking action when they are looked after in this group clinic model. So, it's been an amazing day today. There's loads of activity in the chat with everybody writing some really lengthy emails. So do feel free, speakers, to pick up on the ones that relate to you. I'm going to hand over back to Alicia now. So if you wouldn't mind just popping in a note in the chat rather than speaking, that would be really helpful. And likewise, Jackie. And we'll just take you through a few bits and pieces of information about how you could get involved and get access to training.
Perfect. Thanks, Georgina. So I'm just going to wrap us up now towards the end and tell you about our training that we have here at ELC. So we have been working with teams for just over a decade now, gathering knowledge from best practice to construct a learning platform that trains you on how to deliver group clinics, but it also helps you to embed them and overcome known barriers that other teams have also experienced in the past. So you can see here we've got the support programme, which begins with a live orientation session to help you get to grips with the platform and make sure you set off on the right tracks. We have our simulation, our basic, and our advanced skills modules, which are all available online. They are fully virtual, so you can pause and play whenever it is convenient to you to hopefully assure minimal disruption to your patient care. We also have our route map, which contains over 150 resources that you may or may not need to deliver group clinics. So there are templates there that you can lift and take and use in your own practice or in your own work. And there are links to our webinars and our masterclasses. With the support package, you also get access to our support desk. So if you have any unanswered questions throughout listening to the training, you can contact us for more information.